Good day, folks. This is Dave Lindell. I want to go over the slides we did the other night during the presentation. There was apparently some trouble recording it there, so we'll bang on through these pretty quickly. That said, is this review necessary? Yes, it is. We kind of can see with folks that we don't adequately ventilate them quite often, and we all need to be better about it. And it's obviously a critical skill that we need to have. The technology has changed as well as the science, the way we ventilate with volumes, etc. And the scope of practice has changed for EMTs, advanced EMTs, and in some cases medics as well. Now let's go on and take a look at anatomy. We can't ignore anatomy when we deal with this. The respiratory system starts at the tip of the nose and the lips. We go through the nasal cavity back to the nasopharynx. Turbinates, 3 of them on each side, superior, medial, and inferior. You want to stay out of those with devices. They'll just get yucky and bloody if we go banging into them with tubes, airways, etc. Obviously, the hard palate is there for us as well. That's going to be a guide. We'll be putting things across the base or the top of that. And as we go through the lips, we'll come to the tongue. It's going to be attached to the jaw, so we move the jaw as we need to move things around. Proceed back into the hypopharynx, and we see the retropharyngeal space, a place where we sometimes get abscesses or can have growths or can damage things if we're too harsh. The epiglottis, a little trap door that closes over our glottic opening, which is the space between our vocal cords going into our trachea. And then behind all that is the esophagus, the way down to our stomach, obviously. When we start talking about airways, we have a need to make sure we have appropriate PPE on. Gloves minimally. If you wear glasses, that's a big help. That's the way I function a lot, but I'll also throw on goggles or some form of shield for my eyes to prevent splatter if I'm going to do an intubation. Also, a mask is good. Remember, our mucous membranes, our eyes, our nose, our mouth, are portals into our bodies where we can get infected by infectious material should the patient actually have an infection that they are sharing with us as we yuck around in the airway. Can't talk about the airway without talking about assessing level of consciousness. Obviously, if they're alert and responsive and maintaining their airway, life is good. If they only respond to verbal, it may be less well. If they only respond to pain, it is less well. And if there's no stimulus, we've got a problem that we have to watch. When you document your level of consciousness, please make sure you describe the response. Don't use a variety of words like obtunded. It means different things to different people. So we want to be very succinct about how we do that. As we go from level of consciousness to assess our airway, one of the big things we're going to look at is chest rise, but just the chest attempting to rise through a occluded airway will not give us all the data we need. We need to listen for airflow, air in and out of the mouth and nose. That'll mean air is actually being exchanged when the chest rises. We can feel for airflow as well. A word about listening for airflow. A noisy airway is a problem airway for us, and we will talk a little bit more about that beginning with the next slide. Is your airway maintained by the patient? If they are, that's good, but we need to monitor them closely to make sure that does not change. If you have to provide the airway, we're into the game at this point in time, and you need to watch that and maintain that throughout your time with the patient. And it's important for us to note if there are protective reflexes present. However, I would not ask you to stick a spoon or an oral airway or a tongue depressor down into the back of someone's throat to see if they have a gag. Because if they do, and if they have a loaded belly, you've just pulled the trigger on the gun, and you may very well now have a problem controlling the airway due to vomiting. We talked about a noisy airway being a problem airway, and you need to deal with problems as you find them. I have entered houses behind BLS ambulances um, as a medic many times, and here's grandma on the couch, pillow under her head, non-rebreather on her, and she's snoring. What's wrong with that picture? Well, they've got the oxygen on. That's a good thing. She's still breathing. That's a good thing. She has a noisy airway. She's snoring, or perhaps she's gurgling. All right. And I've had both of those happen to me. We need to remove the pillows out from the head. We need to position the airway so she doesn't snore, or we need to position her if we can so that she drains, or use suction to get rid of that. More on those things as we go. As you're establishing a patent airway, the recovery position we sometimes laugh about and ignore, but if they're uninjured and adequately breathing, we need to consider using it. My last full-time job was a hospital coordinator in a tertiary or quaternary, if you wish, because they play games with names, center. I mean, it did trauma, it did cardiac caths, it was comprehensive stroke. I mean, it did it all at a level 1 level. And we saw a lot of ambulances because of that. And I got to tell you something. A lot of unresponsive patients come in by ambulance, and we're ambulances. That's why we're talking about this. All right. They come in and they're on their backs and they're unresponsive and they don't have endotracheal tubes in. Probably not the best. If it's safe to put them on their sides, we should probably be transporting patients on their side, probably their left side, because you and I might be sitting on a bench watching their airways, and that would be important to have that access. A head tilt chin lift will work if they're uninjured. Modified jaw thrust used to be in vogue if they were injured. I would suggest we can still find uses for it. It's been controversial one way or another. But I would like you to figure out what works best for your patient and make that happen. That is being done in context with your protocols and what your medical direction wishes. We also have our BLS airway adjuncts, oropharyngeal airways, nasopharyngeal airways, and certainly the suction. Okay, so let's talk about some of those airways. We just talked about positioning. If we talk now about oropharyngeal airways, we have a lot of rules about them. There's two that I'm going to insist on. Always measure it. The wrong size may obstruct the airway. If they're too small, it may push the back of the tongue further into the airway, which devils us and doesn't accomplish what we wish. And if they're too large, it is possible for that tip that you're placing into the airway to fold that epiglottis down over the glottic opening and create problems from that particular airway obstruction that you've now made. All right. We only use it if there is no gag reflex. If you place it in there and they gag, get it the heck out of there before they vomit. When you measure it from the corner of their mouth to the angle of the jaw or their earlobe. All right, so you get the right size. Probably we are guilty of placing too small an airway in patients most of the time. A lot of us have been taught to insert it upside down and rotate, certainly for adults, and go straight in with control of the tongue, like with a tongue blade for kids, or grab the tip of the tongue with a 4x4 and pull it out as we put it in. I don't care. I don't care if you put it in upside down and rotate it 90 degrees. If you're doing it in a patient who is snaggletooth with one loose tooth in the front of his upper jaw, be careful, because it may end up in their airway, and that's bad. All right, for us. So you can put it in upside down, rotate it so it drops in place over the tongue. You can put it in at 90 degrees, starting with it in the corner of the mouth and flipping it 90 degrees so it drops over the tongue. Or you can just trap that tongue, pull that jaw up, and stick that airway straight in, and that will work as well. It does not protect the airway like an endotube. You folks know that already. So the rule for placing it, all right, Get it in without carrying the tongue back. Make sure it is the right size. And here we go now, just taking a look at it. These are Berman Airways, I believe. They look like an I-beam if you look at them in cross section. The Goodell Airways are the ones that are circumferentially completely round with tracks down the center of them. Doesn't matter which you want to use, the rules are the same. Okay, let's talk about sticking something in the nose. We don't do up the nose with the rubber hose, because if we go up the nose with the rubber hose, we go into the terminates, which we mentioned earlier, all right? And that can be a real problem for us. The nasopharyngeal airway, we generally don't measure with length, but if you were going to do that, it would be measured from the tip of the nose to the earlobe or the angle of the jaw as you do it. I don't measure them that way. Generally, the airways, the nasal airways I have are trumpets. Some of them do come with sliding rings, which can adjust the depth, but for the most part, we insert them until we get great airflow and we leave them there. My rule for these in terms of the size of the airway is you use the largest diameter that will fit through the external nair without forcing or causing trauma. It must be well lubed with a water-soluble jelly. You need to park the biggest car you can in the garage without taking the mirrors off the side of it, is the way I think about it. Because you're already going through a smaller opening into your airway anyway, and this just reduces the size a little bit more. We're taught to insert it with the bevel towards the septum. Nothing wrong with that. Rotate it in advance until the flange sits. I will tell you right now, do not go up the nose with the rubber hose. Go straight back from the nair. Make a little piggy nose if you need to. Just push it up just a little bit and then insert it and drive that back along the center line against the septum and the floor, all right, of that nasopharynx towards the external auditory meatus. That's right, your ear opening. It does not protect the airway, so if they're going to vomit, you're going to have problems there as well. But do know that this is an airway that can be well tolerated in patients that are awake. The ones that I probably have most frequently seen it in are the narcotics overdose that we reverse, where we've been bagging them and have a nasal airway in, and they'll wake up and they'll talk to us, and then all of a sudden they'll realize there's something up their nose. We just pull it out. You can keep that if you want it. That's the way that goes. So we can use this on folks as we need to. There is nothing wrong if you're having trouble with airway control and maintaining it to have an oral airway in and have two darn nasal airways in place, one in each nair. Seems like a lot of stuff, but it'll work if it keeps it open and keeps you having the ability to ventilate your patient. All right. The biggest one you can without trauma. Well lubed, stay midline, straight back to the ear. If you put it in the left nair and you're trying to do the bevel against the septum, the airway will be upside down generally, and you'll rotate that kind of counterclockwise until it drops into place going back, all right? Suction, it's got to be present. It's the old line. If you have it, you won't need it. If you don't have it, you're damn sure going to need it, all right? It needs to be in working order, which means your battery is charged, your collection chamber is there and tightly sealed, that you have the connective tubing that goes from the chamber to your suction catheter. I frequently use that large bore suction catheter, not suction catheter, but the suction tubing itself as my means of suctioning, because it's the largest diameter that I have if I need it. The Yankauer suction, the hard tonsil suction, the pharyngeal suction is good in just the mouth and the hypopharynx. The soft catheters can be used everywhere, through the mouth, into the hypopharynx, down endotracheal tubes, through the nose if you need to, and everything else. You should measure your soft catheters as well, depending upon where you want to be. They say suction only on the way out. Sure, that's probably the best thing to do. for you, and suction no longer than 15 seconds is generally the rule that is taught. I will tell you right now, when your patient is down and has had a gallon or two of beer and 6 chili dogs, that they may very well be vomiting for the next 42 hours. All right, that's an exaggeration, but it's going to be longer than 15 seconds, and there's no sense just suctioning for 15 seconds and then blowing that goo back down into the trachea and lungs. Don't do it. Roll them on their side, tilt their head to the side, scrape it out with a gloved hand. I've even so far as log rolled them up on their side, pressed on their stomach just to get that distended belly to empty all the crap that's in it out while I could control the airway, sweeping it with my fingers, suctioning with a suction device to get that airway clear, put them on their back then and go to town to ventilate them. I will say that, it's hard if there's two of us going into the place, you and I, carrying all the gear that we need to necessarily have the larger battery-powered suction units with us. And one of the things that we did in some of the places that I worked is we took the handheld that you have to squeeze and put that in the airway side pocket with everything we needed, so that we always had some degree of suction available for us every time we went into the house with a bag. You should consider doing that, because as I said, if you have it, you will probably not need it. If you do not have it, you're going to need it. That is for sure. Let's talk about oxygenation and ventilation. They are two sides of the same coin. They are different, all right, when we deal with it. And you need to know that oxygenation obviously provides oxygen to our patient, combats the hypoxia and anoxia that they may develop by not breathing well. It is essential for metabolism for us, prevents the anaerobic metabolism from developing, and that prevents us from turning our substrates into lactate and lactic acid, all right? Oxygenation should be optimized in all ill or injured patients, but we don't want to create hyperoxia if we can help it. And we'll talk a little bit about that as we continue on. Let's talk about the ventilation for a second here, right? Ventilation is the movement of gas into and out of the lung. It's essential for the delivery of oxygen and the removal of waste gases. A gas exchange is going to occur at the alveolar capillary membrane in the lung, also in the respiratory bronchioles, almost into the alveolus. And the absence of adequate ventilation is going to help build up CO2. CO2 in the body turns into acid, carbonic acid for us, and contributes to our acidosis or respiratory acidosis. The basic rule that Ron Stewart taught us years ago, if you don't know him, Google him and look him up. In Pittsburgh, when Steve and I were working there, his line always was oxygen is good, blue is bad, and air must go in and out. That is true, all right, for us, and we need to keep that in mind to make sure we do it. A word about delivery devices, all right, can only be used in the adequately breathing patient. It's going to require an oxygen source. Non-rebreathers are generally what we use, 10 to 15 liters a minute, though with a tight fit on people that can tolerate it. We do want to be careful with that in terms of saturations, and we'll talk, as I said, a little bit more as we continue on. Nasal cannulas, for those that can't tolerate it or those that are oxygenating pretty well, at 2 to 6 liters a minute. That'll work. I will tell you right now, in our cardiac arrests, when we go to intubate them, we have nasal cannulas on them with 25 liters a minute flowing through there to help prevent the development of hypoxia as we do the actual intubation. That's apneic oxygenation, APOX. So we use it in a variety of different ways. Let's talk now about the assessment of ventilation. Chest rise is a gold standard for us. An expansion, it's important. It gives you an idea of how much volume they're getting for rates for us, adults 12 to 24. Kids are faster. Slower or faster rates are an indication of a problem and need for intervention. We want to listen for airflow. We already said that. It gives us an idea of what's going in and out. We also want to look at the work of breathing, if they are breathing for us. Are they using accessory muscles, supraclavicular muscles, intercostal muscles, etc., belly breathing? And then we like to listen to breath sounds when we have the opportunity. Are adventitious sounds present? Are they wheezing? Do they have crackles or rails? Do they have rhonchi centrally when we're listening to it? And that'll give us a clue as to how well we're ventilating or they are ventilating if we need to. And there are requirements that we have for ventilation. And we need a patent airway first and foremost. That's really what we've been talking about a lot. We need tidal volumes. Back in the day, they used to talk about large volumes, and you were trying to squeeze everything you possibly could out of an adult BVM, and it was just too much. And we would end up with pressures that were too great, ventilatory speeds that were too great, and what have you, and create problems. So we need a patent airway. We need a reasonable, rational ventilatory volume. Somewhere between 6 and 8 milliliters per kilogram is about right most of the time. We need a rate between 10 and 12 if they're not breathing on their own, a little faster in kids for sure. The duration, generally about a second with a deliberate squeeze of the bag. We'll talk more as we go. Peak inspiratory pressures between 20 and 30 centimeters of water. We prefer it to be less than 20 where we can, because the esophagus tends to open around 20 centimeters of water, and you'll just be blowing air into the gut as well into the lungs. And when you do that, we said we load that weapon for vomiting to occur. Supplemental oxygen as we need it, and we like to prevent that gastric distension and vomiting wherever we can.
Wait, stop.
So continuing on about ventilation, it fails for us for a lot of reasons. We cannot maintain a patent airway. We don't maintain a mask seal. We don't give a good tidal volume. God help us, right, with that. We generate high peak inspiratory pressures, inflate the gut when we do it. We don't know the equipment, all right? Think about people you've seen that put masks on upside down with the narrow nose section at the chin. Sometimes you can ventilate people like that. Sometimes, and it goes unnoticed. Other times it's clearly that there's a leak, right? Or we ventilate too slow, or more importantly, too fast. And I've seen a lot of people when they take over breathing for folks, if we have an endo tube in, they'll just be squeezing the bag like it's going out of style about 60 times a minute, 30 times a minute, way too fast. And a word about mask seal, right? I mean, that's a very critical element for us, and we need to think about how we maintain that seal and not cause problems. So there's some tips we can share about you, or with you rather, not about you because I don't know you, all right? But ventilation tips are helpful if we deliberately establish the airway, all right? And we need a mask that fits for kids particularly, so we need to carry a variety of mask sizes. Too big can leak, too small won't do the job necessarily. We need to pull the face or jaw up into the mask. It is very normal that if there's a mask leak and we hear it, and I've heard that many times arriving on the scene with folks ventilating somebody with a bag, and you'll hear shh, shh coming from there, and their response to it was to push more forcefully on the mask. And when they've done that, they move that mandibular block posterior word, blocking the airway, and they take the hyperextension out of the head, again, to block the airway. And they're just happy as a clam, squeezing the bag and letting the mask leak and not having an airway. Don't do that, please. Pull the jaw and the face up into the mask. That should keep your jaw forward. That should keep the head in hyperextension and make things work a little bit better. Deliver an adequate tidal volume, enough to make the chest rise, but not enough to make the patient shoot across the room every time you squeeze the bag. A deliberate squeeze, and I don't mean a fast spike of the bag, a nice gentle squeeze of the bag over a second's time will help keep that peak inspiratory pressure lower, and you should see a visible chest rise if things are working for you. Now, there are a bunch of ways to ventilate, folks. We're going to talk about some of them. Mouth to mask is a good one. We like to add O2. Two operator BVM is probably preferred, and sometimes that second operator may very well be a bystander, a family member that's together enough to be able to follow your instructions. One operator BVM, certainly doable. I'm pretty darn good at it after so many years, and but I'm not always perfect at it. So I like to use two operators whenever we can. And then mouth to mouth, certainly I would use that with family members, people that I know. Maybe, I'll be honest with you, I've been in the business for more than 50 years. I've done it probably a half a dozen different times in my career. It was all early in my career because I've never needed to ventilate someone that I've known and loved. Thank you very much for that, Lord. But early on, we've done that back in the day before probably AIDS was around in the early 80s, and we got a little bit more serious about our PPE and what we were doing. So let's talk about these ways of doing things, right? Mouth to mask, great tidal volumes, man, because I have a pretty big set of lungs with it, right? We do it with O2. If we are, we'll get at least a 50% fraction of inspired oxygen, right? Equipment is compact and inexpensive. I always carried a pocket mask on a little adjunct bag I had that I'd sling over my shoulders if I didn't have a chance to check the truck as well as I should have, come through the door and your partner's handing you the radio and you're going out the door before you can check anything. And that's a lot of the services I worked in. So I would have that. It could go with me if I needed something. I knew what was in that bag. I'm not always sure that whoever you relieved replaced the BVM or whatever after their last arrest and could barely get back to the station in time to give the next call to you. It is inexpensive. You can have it around. We had it in every bag as well with a BVM. It is placed in service quickly. It is simple and easy to use. And really, if you're honest, you have two hands on the mask to seal it, and you can watch the chest rise, and you can maintain the airway, and it works very, very well. Although most of us won't do that, it brings us in close proximity to our patients, but it's always there if we need it, all right? BVM skills are basic skills, but they are not simple. They're done poorly by a large number of us. You guys know if you're guilty or not, all right? It is a essential skill for us to have. It is a complex skill because we have a lot to think about. It requires detailed training, including immediate feedback. So if you're not doing it right, you need somebody to tell you, hey, that didn't produce a chest rise, or that's too much volume, or whatever it might be, okay? It should have regular practice. Somebody should leave mannequins out for you to practice with at least once a month, because you may not be ventilating somebody once a month, or you may be ventilating somebody twice a shift. I don't know what your rate of response is and the acuity of your patients, all right? You need to do this with a thoughtful application of the technique, because we're all smart and can all do this. So what are some of our considerations that makes this complicated? Tidal volume, enough to make the chest rise, not enough to have the patient shoot like a loose balloon across the room. Peak inspiratory pressure, I don't want to inflate the gut, insufflate the gut. That's bad technique, and it's going to lead to problems with vomiting, all right? The inspiratory time, generally over about a second. The flow rate, deliberate squeeze of the bag, not a quick spike of the bag, because that'll give you The deliberate squeeze will give you a lower airway pressure, peak inspiratory pressure. You also need to pay attention to lung compliance and resistance. That's the stretchability of the lungs and the airway resistance. And if that's changing, and it feels like it's getting harder to ventilate, you need to check your airway, and you need to think about what processes, maybe a pneumothorax, it may be developing, giving you trouble, and you need to bring that to somebody's attention and deal with it yourself to the best of your ability. How much oxygen is going to depend. We like to have a 99% saturation, and let me just say, with 100% saturation, we need to be a little careful, because that 100% saturation looks really great. And if I have 100% now, which I probably do talking to you, and hopefully you're not sleeping and have a lower saturation right now. But we want to avoid that hyperoxia, and arterial, the partial pressure of arterial oxygen with 100% saturation can be anywhere from about 88, all right, to about 550. Okay, and obviously the 500 to 400 to 300 and 50 is a big indication that we have hyperoxia. That's going to give us free radicals, which are charged particles, which can help degrade membranes of the cell and make them a little leaky and problematic, which may reduce or positive outcome to some extent. So we don't want to do that if we can help it. And then we need to think about how we use whatever device we've chosen and have the appropriate techniques with it. 2-operator BVM is preferred if we're doing it. Good tidal volumes, because you got one person to squeeze the bag. As I said earlier, it could be in control family member if you needed to do that, or bystander to give you an extra set of hands. The 1-operator will maintain mask seal and airway control, the hyperextension, the jaw displaced, etc. Works really well that way. The other operator squeezes the bag, and you can coach a non-medical person to make that work. Use O2 to provide 98 to 99 saturation. We just referenced that. The 2-operator bag is going to give you at least 80% with 15 liters of oxygen going into it, maybe more. And it works with room air. Don't forget that. One of the strangest things I ever had to deal with in the last couple of years is not wanting to have hyperoxia and having cardiac arrests that we've resuscitated. They have blood pressures, pulses. They have good SpO2s when we're measuring them, and I'm turning my oxygen down after years of running 15 liters through a bag valve mask. Every time I get it, I'm turning it down to 10. I still have 100%. I'm turning it down to 6. I still have 100%. I turn it the hell off. I still have 100%. And I went in with 100% on room air, but it just felt so weird not having the oxygen flowing in there. But I could watch my saturation, know that 100 on room air is okay, because it's not going to be a 550 at that point in time for a blood gas. All right. 1-operator BVM, got to be skilled, folks. Got to practice it. Got to be real good. Mask seal, airway control, tidal volume, peak inspiratory pressure and flow rate, all things that you need to control yourself with a deliberate squeeze of the bag. And you'll use O2 with generally at least 10 liters a minute as a minimum to start, to see where you're at. Mouth to mouth, not recommended for the unknown. We don't want to catch anything, and Lord knows there's a lot of stuff out there. It is certainly okay with barriers, which is all right, not mouth to mouth, but mouth to barrier if you want to do that. Foils and etc. are there. It'll give you good tidal volumes if you can seal everything, mouth and nose. No equipment is necessary other than the barrier of whatever choice you made, or if it's a loved one or somebody that you know is okay, or if you're just feeling jiggy, because the odds of getting something from somebody are actually pretty small, unless you know there's ongoing problems. You want to do it with protection, all right? FiO2s, when we exhale 16-17%, you only use about 5% with every breath you take. So there's more than enough oxygen to keep somebody going, and we've done that. Now, a word about neck breathers. They're out there. They're your laryngectomy patients, all right? Their airway opens to the environment through the neck with a tracheal stoma. All right, they may or may not have a trach tube in place. They must be ventilated through the trach tube or stoma. You can seal that opening with a small pediatric mask, usually in adults. The head and neck doesn't require the same degree of attention to position that you and I have when we're trying to ventilate with our other techniques. However, we always pull it up and back. That gives us more room to work on the neck. So we do that as needed. And remember, there are partial laryngectomy that breathes not only through their neck, but also through their mouth and nose. If that is the case, and we are going to ventilate through the neck, we will need to close their mouth and nose to make it sealed so that the air doesn't just go in the hole in the neck and out the nose and mouth, which may be the path of least resistance. Going forward here, let's talk about ventilation and advanced airways, all right? No mask seal on the face. The seal is moved into the hypopharynx or the trachea, depending upon what the device is. It must be managed in such a fashion that you prevent the device from moving in or out or dislodging. All right, that's critical. So we'll need to know its depths and have it marked and watch it. Remember, anytime we have invasive airways in like this, we bypass the role that the upper respiratory tract pays. It hopefully prevents us from having aspiration, but not always. There's micro aspirations even with endotracheal tubes, but they're not big, and we want to be aware of that. So just don't ignore vomit or fluid in the airway, even if they have a tracheal tube in place. The devices you need to have an idea about are endotracheal tubes, I'm sure. I don't know for sure if everybody is or is not using King Airways or LMAs, laryngeal mask. I know you are using eye gels, all right? And I don't think you're using combo tubes, but if you are in a place where you encounter King Airways and combo tubes or the inflatable LMAs versus the eye gel, you need to know that as well as you know the eye gel and the endotracheal tube. Endotracheal tubes, you folks already know, it goes into the trachea per se through the glottic opening beyond the cords. On the right of this picture, you see the shiny cuff down there inflated in that picture past the cords. King Airways, these are retropharyngeal devices in so much that they are or retroglottic devices. They're behind the glottis. You'll see a distal cuff there that is in the esophagus, and that helps to limit vomiting, but it won't prevent it. All right, and then the opening to the tube where you're ventilating is right outside the glottic opening here as well, and then there will be a proximal cuff which will inflate in the hypopharynx itself to seal things for us. The combo tube has two tubes. It's placed blindly, just like the King Airway and your eye gels and your LMAs. All right, has two tubes. It can sometimes end up in the trachea, so you need to assess ventilations, find out where it is, and use the appropriate tube. It has a cuff that can be inflated if it's in the trachea. It also has that same cuff which is inflated in the esophagus, which is where it's designed to be, and it has the hypopharyngeal balloon, which is the yellow-brown balloon you see there. You want to make sure you're using the right tubes, and you want to, again, always pay attention to the quality of your ventilations. What you guys and gals are using are the LMAs, or rather the LMA style, the eye gel, which does not have an inflatable cuff, which is nice. They're going to be inflated by size, like every other device we use, one way or another. There's by weight, if I recall correctly. These are supraglottic devices versus retroglottic devices. So they need to be lubricated well. They're a blind insertion. You're going to insert them in the midline. I would just always hold up on the jaw And the tongue, I get that as a habit, to be perfectly honest with you, because it'll allow it to seat a little more securely and a little more easily. Um, Assess it and secure it when it is ventilating the patient the way it should. Monitor it closely. And your monitor for any of the invasive airways should always include end-tidal CO2 monitoring, which you may or may not have at a BLS level right away. But if you're working with ALS providers or you're lucky enough to have the monitor available, use it. As we keep going here, things to remember: make sure it does not move in or out. Check and know the depth in centimeters or placement lines. Please pay attention to noise in the airway. You shouldn't have it, right? You have a sealed airway there, and it shouldn't be giving you noise. And if it starts to, you need to pay attention to that. Monitor closely for the changes in the way the bagging feels in terms of compliance and resistance. Watch your capnography rate in real time. It's wonderful. You teach people this, and it's like they're no longer ventilating 36 times a minute. They're ventilating 10 or 12, which is what they should be doing. And watch your SpO2s if you have them. So here's just a screen of a LifePak 12, if I remember correctly. The top tracing is your EKG, although I think that's a funky looking picture. Probably looks a little bit like mine, although mine's wider at this point. I'm old. Rate 74 on the top there. As we go down here and look, it tells us that our saturation is 98% that we've got there, all right? And then the second waveform down that looks like plateaus is your end-tidal CO2, and it's normally 40 plus or minus 5. So 35 to 45 would be okay. 37 is what it's running here, and you will see under it that the ventilation rate is 12. Whether they're breathing spontaneously or you're breathing for them or doing both, it will give you the combination. A word about alarms and SpO2 and CO2. CO2 monitoring is safer. It is better than just using pulse oximetry. I can have a pulse ox of 99%. I can kink a tube and fail to ventilate you if I'm doing that, or have things come apart and not ventilate you, and my saturation is going to drop, and 3 minutes down the road it may still be in the 90s, and that's 3 minutes without ventilating somebody. That's a bad thing. That's not working. The end-tidal CO2 monitors generally alarm in 20 to 30 seconds if they're not being ventilated. So it's a great reminder and safety factor for us as well. You then see blood pressures, all right, on here, two different places. One's going to be a cuff, one's going to be an art line. That doesn't matter. CVP you don't care about, which is that bottom tracing. I really don't care about that much unless I'm doing critical care work at the time, all right? Let's just talk about the waveforms so you're familiar. I think you probably are already, but not knowing that will do it. These are the normal expiratory waveforms that you got here. And your expiration begins on the baseline, which is 1 there, if you will, okay? And it's 0. Because the first 150 cc's of air most of us adults blow out of our airways didn't participate in gas exchange at all. So you won't have CO2 in them. Then all of a sudden, as we start to get further into our expiration, it'll shoot up suddenly at 2, and then it will get to the alveolar plateau at 3, running across the top there. And it goes up to letter D, which is our end-tidal actual number, all right? And then it drops off at 0 as we ventilate or the patient inhales. So that's the way that waveform looks, and that's why it looks the way it does. You know, if you have an asthmatic or someone with COPD that's wheezing, you may get a shark fin where it's rounded in the front going up the C. And that'll tell you you have some bronchospasm there. The numerical data on here is in millimeters of mercury. The baseline should be 0. There are reasons it may not be zero with retention, and that's a problem. If you have somebody on a ventilator, I'm not going to bug you guys with it at this point in time. Here's a little slide for a little help, please. We all help one another. I have been a senior provider every place I've worked in the last 30 years, because I've been doing this for 50 years. All right. And I've gotten a little bit of respect because at most places. And, people will look at me when I come there. You want to do the intubation? No, you do the intubation. Let me open the package for you. All right, let's help people. Let's teach people. Let's get them moving forward and make things work for us one way or another. The Burt maneuver is backward, upward, rightward pressure on our airway anatomy in the neck. Generally, your intubation operator will do it. They may ask you to do it after you've been ventilating and they come in. So help them out. Also be ready to have suction going and opening other size tubes if they need it. If you're using bougies, it's a bougie, not a booger. I hear people joke about, hey, hand me the booger. Keep your fingers out of your nose, folks, and work with the bougie. If you're working with it, ask your ALS providers if you don't know what they want, all right? And always help secure the device and make sure it stays there. My head's just about empty because there's not much in it to begin with. So with that, questions, concerns, gratuitous harassment, I'll leave you to check with Steve about that because I'm obviously not online right now. Have a great day. Hope this is helpful to you.